So I'll talk about prevention of type 1 diabetes because you all know that the insulin is not it's just a therapy and not a cure for type 1 diabetes. That's yes, that's the well-known logo of American Diabetes Association. Philip talked already about it. So it's been long that we know that there is immune dysfunction. So also the antigen presenting cells, but the CD4 and the CD8 cells. CD8 cells are one of the first cells that go into the islets of Langerhans. But more and more there are also data that it's not only the immune system, it's also the beta cell that makes that the immune system is so active and destroying the beta cells. So probably there's something in the beta cell of apoptosis or necrosis that also starts and activates a normal immune system to attack the beta cell. So it's a bit circulus viciosus. And the stages, well, you know already, a genetic risk, then something, a trigger event, and then we have 4 stages. Stage 1 is the stage where there are 2 antibodies, but still normal glycemia. And I will talk about prevention, primary, secondary, and tertiary prevention. And let's start with primary prevention. So here you interfere with a naive immune system. So it means that the immune cell have not yet attacked the beta cells in the islets of Langerhans. So in fact, you want to do something here, and you treat completely healthy people. That means that you have to have a good prediction for who will develop type 1 diabetes. You have to have 0 tolerance for side effects because you treat healthy people. And you have it's necessary to have a long-term follow-up. One of the first primary prevention studies was a trigger study, especially in the Scandinavian countries. And so they looked at first-degree relatives and randomized these newborn babies with a first-degree relative with type 1 diabetes in 2 groups, those with a casein hydrolysate and the other ones with a normal cow milk. And then after years, 4 or 5 years, they looked at the antibodies, and after a mean time of 11 years, they looked at the incidence of diabetes. And unfortunately, you can see that after 11.5 years, there was no difference in the incidence of type 1 diabetes between the 2 groups. This means that these findings do not support a need for to revise the dietary recommendations for infants at risk. So that was a bit a disappointment because we couldn't advise anything. And so there's the GPET, the Global Platform for the Prevention of Autoimmune Diabetes. That's a consortium that provides an international infrastructure to enable primary prevention trials in type 1 diabetes. So, and before getting to primary prevention, you have to identify those children or babies with a genetic risk for type 1 diabetes. And that's the Frederick study that runs in Germany, Poland, Sweden, UK and Belgium in around 14 hospitals in Belgium. And in fact, all newborn babies can be offered to be tested for an increased genetic risk for type 1 diabetes. So the blood test is done on the day 5 when the other newborn screening is done. It's an extra filter card, and then the blood will be sent to UK for a genetic analysis, and then after some weeks we get the results if there is an increased risk for type 1 diabetes. Around 1% of those tested have an increased risk for type 1 diabetes. And until now, around 450,000 children are tested in this study, and around 30,000 in Belgium. So, and what does it mean if you have a risk, an increased risk? It means that you have a risk of 1 in 10 to develop multiple autoantibodies by the age of 6 years. So normally, if there's no first-degree relative, the risk is 1 in 250. So it's a clear increase. So if other centers would be interested to offer this possibility to their newborn babies, they can always take contact. So, of course, if you identify babies with an increased risk, you have to offer a prevention trial. And so the first trial we offered was the POINT study. This was a study where we treated placebo-controlled, randomized babies with oral insulin. Why oral insulin? Because the theory is that if you give something by mouth, you induce oral tolerance, and the antibodies to insulin are the first one that appear. And so by giving oral insulin, we hope that we can prevent this autoimmune attack. The results will be known end of 2024, because inclusion is already finished. The second study is the Cynthia study, in which a probiotic is given, again blinded and placebo-controlled. What's the hypothesis here? Well, in different studies, they've seen that there is a dysbiosis in those children that will develop type 1 diabetes. And we know that mucosa-associated lymphoid system is very important in the development of autoimmunity. So we hope that by giving good probiotics, the immune system will be different and will be less aggressive and induce less autoimmunity. So it's Bifidobacterium infantis that's given. And until now, there are about 880 children included in this study. And so probably by the end of this year, this study will be finished as well. So that was primary prevention. So Frederick's study, you identify those with an increased risk, and then you propose intervention studies, POINT and Cynthia study. Then secondary prevention is prevention when there are already antibodies. So the autoimmune attack has started, but no diabetes yet. Before you can start with these studies, you also have to identify children with multiple autoantibodies. Well, in Germany, in Bavaria, there's the FRIDA study, in which they collaborate with local pediatricians, and these pediatricians propose to all their children they see to do a capillary blood test where they measure the antibodies. If these antibodies are positive, they come back for a real blood test for antibodies. So around 173,000 children were tested already, and 500 were found to have multiple autoantibodies. Then there was a metabolic staging and an oral glucose tolerance test, and as you can see, most were still in stage 1, but 4% were real diabetic. These children were also offered an intervention study, also with oral insulin, and also this study is completed, and the results will be probably known in 2025. And then Professor Mathieu and Annette Ziegler, that's the one from Bavaria, have now recently got funding for a big project. It's called Identify, and it will do the same as the FRIDA study in Bavaria. It will give the possibility to children to have capillary blood tests to look at autoantibodies. Okay, and then probably they will also present, propose intervention studies. Then there's another project, it's the Pre-Type 1 Diabetes Registry. This is a network of investigators who registered all those children with positive antibodies. And that makes it, of course, easy if there would come a trial, a secondary prevention trial, all those people with positive antibodies can have access to these trials. What has been done already, you all know, a lot of things have been tested. The most important and well-known interventions were nicotinamide and oral insulin and subcutaneous insulin, but that didn't help. But then we have, of course, the teplizumab test, where a 14-day course of teplizumab was given, placebo-controlled also. And what they saw is that around 72% of the participants in the control group were diabetic after 24 months, whereas those that received teplizumab, it were only 43%, and it took longer to get diabetes, which is of course very important, this 2-year delay, because we know that as long as you have C-peptide for the future, it's important because you have less complications. So FDA in November also approved this medication, which was very good news, but don't be too happy. It's very expensive. As you can see, it's for one therapy, it's $195,000. So it's still a quite expensive medication. So we had secondary prevention, those with antibodies, no diabetes, and then tertiary prevention. Once you have diabetes, we try to keep those beta cells that are not yet destroyed, we try to keep them as long as possible. So you're here. Why? Because it's been shown that as long as you have C-peptide, as long as the beta cells are not destroyed, you have on the long term less complications. Also, a lot of things have been tried out. And then with the Inodia consortium at this moment for pediatrician, it's important to know that there's a MELT-ATG study where anti-thymocyte globulins are given during 2 days. And it's running in different universities, as you can see. The patient doesn't have to go far, can go to all those centers. And around 100 children and adults are included until now, and there are another 17 to go. So if you have patients, think of the MELT-ATG study. As I told you, it's not only the immune system, it's also the beta cell where something wrong. And so verapamil has been shown to be protective for beta cells. It was published in JAMA, a pediatric study, and now there's running a study in adults. So if adult patients are diagnosed, they can still participate in this. It's just one verapamil a day for a year. And also running in different study centers. So this was an overview of all the possible interventions. And as you can see, I think step by step, we're coming closer to prevention. Thank you.